Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hi everyone, my name is Wilson Lim, a medical writer for EHA. I'm sitting here today with Professor Gregor Hormann to talk about AI, artificial intelligence in hematology. Professor Hormann, would you introduce yourself, please?
Yeah, hi, my name is Gregor Hormann. I'm a clinical pathologist or specialist in laboratory medicine working at the MLL, the Munich Leukemia Laboratory in Germany. The MLL is one of the largest laboratories focusing on patients with leukemia and lymphoma and diagnosis of bone marrow and blood samples.
So when we talk about artificial intelligence, AI, the first thing that comes to mind is all the large language models such as ChatGPT and Gemini. Many people are unaware of the other models that are applied in healthcare. Can you share with us some examples of that?
It's a huge spectrum of AI to be applied in healthcare. For example, where we are mainly focusing on is, of course, using AI for our diagnostic processes. And there we are mainly applying a particular kind of AI, machine learning, or more specifically deep learning, where we try to get the information out of our data and use them in a scientific way with those AI machine approaches. For example, we are doing cytomorphology, or we are doing chromosomal bending analysis. Both of those techniques focus on imaging. So our technicians, our cytogeneticists, our hematologists have to assess those images and tell what kind of cells are these, what type of chromosomes are these. And we can use here deep neural networks, a kind of machine learning approach, to align those pictures to the classes of cells or the classes of chromosomes. So we extract the features out of the picture and then have the network aligning the cell to a particular class, for example, telling this is a blast. And this is very helpful as the cells are pre-annotated. Of course, you need all the data digital. First of all, we have to photograph all the cells from the peripheral blood smear or from the bone marrow smear, or have the metaphases digital available, and then we can apply those AI models to help us in the classification of the particular cells. This is nothing that the AI is doing alone. This is definitely a co-working between the AI and our trained personnel. So each and every cell is then reviewed by a trained medical personnel, and then we have a final report to be assigned. Still, this addition of AI was very helpful in our processes, in particular in cytogenetics. This has really streamlined our reporting. We are much faster now. We can deliver the report faster to the patient and therefore help the patient care directly.
So does AI help?
Yes, so we can use health data to predict and help us with certain tasks. So what I've just elaborated on was a rather easy task. Just tell me, what is this cell? What is this chromosome? So we have a picture as an input and the classification as an output, rather straightforward. Of course, we can also ask more complex questions. For example, is this picture associated with a certain genotype? Or is this picture associated with a certain outcome of the patient? So then we are talking about disease classification, prognostication. AI can also be used for this. Again, we typically are then using machine learning approaches. We can use this with supervised or unsupervised machine learning. And in particular, unsupervised machine learning also helps us to identify new classes of disease where we would not have thought about. We have so much data now available in the area of genomics, where we struggle as humans to interpret all those data, to find patterns in this large field of data. And here AI is helpful to point to certain classes that are biologically similar, depending on their genotype, on the other features, And then we as the humans and the medical doctors have to figure out if those classes are then meaningful in terms of treatment, in terms of prognostication, and how to deal with this.
From all accounts, this also leads to a huge improvement in efficiency. How long would you say it takes to process, for example, an image in karyotyping? Would you say 10 seconds, more or less?
Even faster. Now we are in the range of 1 second, so it's really just get it started and it's done. So that's not a bottleneck. The system is really fast, and to get this into context, a well-trained technician who is doing this karyotyping needs about 1 minute for one metaphase, and you have to do multiple of those to assess one case. So you typically need half an hour to assess a case. And now this is pre-prepared. It still takes some time, but for reviewing. And this is much faster than doing everything from the scratch.
Do you think we can still improve this?
There's always room for improvement. So in the past, we have been focusing on normal chromosomes. The vast majority of those are normal, and we also can assign a numeric operation, meaning just one chromosome in addition or one chromosome missing. This nicely works. However, when we're talking about structural operations, for example, a translocation that leads to a fusion of the chromosomes, BCR-ABL would be such an example with the Philadelphia chromosome. This needs to be specifically trained to also recognize those structurally abnormal chromosomes. And that's what we're currently doing. We're training the system with the most frequent and most relevant structural operations to also have them automatically assigned.
You mentioned morphology. Are there any morphology AI models as advanced as the karyotyping one?
The karyotyping was the first one out there, and this is really something that we have in place in our routine diagnostic application for a couple of years now. Therefore, we have a lot of experience with this, and also other labs are already using this approach, and we know it's really helpful also in their hands. In the field of cytomorphology, we are a little bit beyond this. We need to apply this in our own lab right now. This is perfectly fine. And we are currently in this transition phase to see how robust the workflow is to be also applicable, for example, in other labs.
So if any of our listeners want to get to know more about the karyotyping process, its AI, for example, the benefits or what it takes to set it up, how and where can they find more about it?
You can contact us, we can get in touch. There is always room for collaboration. We have a designated AI team in our laboratory. Currently, there are 5 people working full-time on AI applications in this diagnostic field of medicine. We are enlarging this team right now to up to 10 people that will work at AI. For example, with the karyotyping model, this has been a collaboration with Metasystems and is also available via them directly.
So shifting gear a bit here, can you tell us a bit about how we can use AI to determine patient prognosis?
Yes, so when we're talking about prognosis in hematology, we now rely on rather, simple models because we need to handle those. For example, if you think about acute myeloid leukemia, then we have the ELN certification in 3 different risk groups. It is of utmost importance for the treatment of patients with AML. The patients are assigned to these risk groups based typically on one marker, one genetic operation found in cytogenetics or molecular genetics, and this makes the risk group for this patient. This is straightforward. A physician can deal with this type of information perfectly fine. However, we are losing kind of complexity because in many instances we have combinations of multiple mutations and together with other operations. And to assess this type of complexity, here AI can help. There are a number of studies out there that just asked, are there biological subclasses within AML that can be assigned to a different biology or to a different outcome? And this more evidence-based classification, taking into account the complexity of the disease, will be an interesting way to move the field forward.
So the principle behind this, is it applicable more widely, for example, to MDS, MPNs, etc.?
Yes, the principle is applicable for all those types of diseases. For MDS, we now have the IPSSM that has come out in parallel. There have been multiple publications on other approaches, including also AI for certification of those patients. And machine learning is an issue there.
Moving forward, to what extent do you think you'll be able to implement this in your laboratory, for example?
Yeah, they can be implemented, and they have already been implemented to some extent. The important thing is you have to carefully validate your model. You need to know the performance. How well is it working? What are problems? What are cases where it doesn't work? And this is really a careful validation process that is of utmost importance before you can apply this into a clinical practice. When we are talking about what we are currently doing, these are rather narrow questions that we are asking. For example, how to assign the class of this cell. And this is what we will call a unimodal AI, just one input and one output format. In the future, there are now proposals and models out there that can deal with multiple formats, multimodal AI. This will be a very interesting topic to see how the field is moving with this. We are not there as a current state to implement this in routine practice, but this will be of utmost importance to move forward.
So what is synthetic data? It's a pretty hot topic at the moment. Would you be able to explain more about it?
Yeah, that's an interesting and rather new field within generation of data with AI. So large language models are kind of generative AI, and this is also something a little bit in this direction. So we are not just analyzing data, but we are producing data with this. What does this mean? You have a large data set. Big data is still an issue there. You have a large data set of real patients, for example, and you then train a model to produce patient data sets that are like the real ones, but not a perfect copy of the real ones. So with slight modifications, and those new data sets are then called synthetic data sets. What are pros of this approach? You have better patient privacy, as the real patient data are then not needed for sharing anymore. You can share those slightly modified data, but we can also augment the data set, increase the number, at least to some extent, and to make some studies more powerful with this. That's an emerging field. We will have to see for what applications is really useful in clinical practice and where the limitations of this technique are.
So for all our listeners who are also interested in synthetic data, we will have a specific podcast on that with Professor Matteo Della Porta. If you're interested, please keep an eye out to the episode by subscribing to the EHA Unplugged podcast channel. So taking all the things that you've spoken about, along with the language models being able to suggest reports and other communications, this is moving towards an AI doctor. What is your take on this?
Well, we should not overestimate what AI is currently able to do. So those models are helpful in many instances. They can, help us get rid of the boring stuff to do, and then focus on the complex things. Right now, AI will not be able to solve all the very complicated cases and really get up with much new information on a single case. This is really something where the human is still in the front. However, it is a matter of working with the AI, not against the AI. So it should really help us in our process and not replace what we are doing. And this combination of human intelligence together with AI is definitely the way to go forward.
So what you're saying is that we shouldn't be afraid of AI, but rather we should embrace this change and move forward with it?
Absolutely agree. So don't be afraid. Try to learn about AI, and here EHA can be very helpful with those training activities. trying to learn about their pros, their cons, the limitations, how you can use AI, how you can use AI in a way that is really helpful for you in your daily practice. And yeah, just use this opportunity. It's a great area where we're living right now, and we should not only focus on negative sides, but really get into the doing with this.
There was a wonderful quote at the end of your talk here at the EHA 2024 Congress. Would you be able to share it again with our listeners here?
Yeah, the quote is from Eric Topol, one of the most famous physicians dealing with AI. And he said, AI will not replace physicians, but physicians using AI will replace physicians not using AI. It's a very interesting quote.
Yes. Thank you very much, Professor Hormann, for this wonderful talk. And also thank you for everyone listening. If you're interested in more podcasts, do stay tuned and check out our EHA Unplugged channel. Until then, have a nice one.